Lovely, thank you very much. Good afternoon and welcome to the launch event for the Hostel-Only Discharge Collaborative Approach. It gives me great pleasure to welcome everyone on the call today. It's nice to see some familiar faces on the call, but also some new people. For those who I haven't met either virtually or in real life, my name's Andrew Rochford. I'm a consultant gastroenterologist at the Royal Free Hospital in London and also the Regional Clinical Director in London for the Emergency Care Improvement Support Team. And I'm here with a team of colleagues who are going to launch Hostel-Only Discharge Collaborative today. We've got the agenda up in front of us and I'm going to start off with some overview and some introductions, if that's okay. We're then going to break out into, or we're going to hear presentations from our leads from the four themes around the collaborative. And then we're going to break out into rooms to meet each other, share some ideas before coming back together and just highlighting next steps. So I just thought I'd provide a little bit of context and background for those who are new to this call and have just been asked to join, which I know there are several on the call. There are 15 organisations across the country who ECIST have been asked to provide improvement support to with regards to discharging patients from hospital. Part of our improvement support offer has been a series of 8 weekly webinars which completed last week. We run monthly drop-in surgeries for clinical leads, and I don't mean doctors, I mean clinicians, and we also run monthly drop-in surgeries for more operational leaders or executive leaders which are open for people to attend. And today we're launching our Hostel-Only Discharge Collaborative Approach, which is a 4-month improvement support offer that we will introduce today. Just a little bit of background as well, because it's a good example of things that we have available as resources. We have done these 8 webinars, all of which are available to watch free on demand on our NHS Futures platform. I'll come back to the NHS Futures platform again throughout the presentation, but if you have not signed up to the platform, it's not possible to log in without joining, if that makes any sense at all. I'm a bit of a technophobe, but basically you have to ask to join. We can put the link in the chat box, and then if you aren't a member of the Futures platform, just email us, we can invite you, you then join, and then you have open access to all our resources. So we have done 8 webinars as part of this improvement offer, which are available to watch now. We had 460 people join us for the webinars, representing 55 organisations, and almost 400 people have watched at a later date on demand. And as I say, they're sitting on our Futures platform waiting for you to look at and share with your teams. As part of the approach, the National Task Force have been doing site visits to the 15 organisations. What they've seen is best practice in a variety of places in various areas relating to discharge. They've identified 5 key ingredients, which I guess are not really much of a surprise, that if they're all there, all present in an organisation or on a ward or in a system, leads to better patient discharge and better patient flow through the hospital. And I'll leave it there for you to read, but as I say, there's not very much there that is a surprise, I suspect, to any of us. And one of the things about our collaborative approach is to take these best practice principles and work with you with your ward-based teams to embed them. As part of the improvement offer, the national team asked all 15 organisations to submit improvement plans, and before people roll their eyes, because I'm very familiar with the reporting and all that kind of thing, what we were able to do is identify 4 common themes for every organisation, which I think probably reflect the challenges we all face in clinical practice every day. And we've built a collaborative approach around these 4 themes, which you can see there. So we're going to hear from our frailty leads shortly, our workforce team, our ward and board round team, and we've lumped a kind of catch-all into supporting operational processes, which will be explained in more detail very shortly. So I don't want to give the game away, but there's some familiar pieces in there. The whole aim, if you like, of this approach is to involve all of you to work together and work with us and vice versa around patient-based, ward-based improvements. And to support this, we have set up, again on our NHS Futures platform, an academy of resources. And huge thanks to Dan Smith, who's on the call, who's led a lot of this work, but it's a fantastic resource for you and your teams to use, and this will be the sort of, if you like, the mechanism by which we support the work, the improvement work over the next 4 months. In addition to that resource, all of the ward-based teams will have access to QI coaching from our improvement managers, most of whom are on the call today. There'll be clinical coaches based from our pool of clinical associates and clinical directors within ECIST. There are 4 dedicated learning events for each theme that everyone is welcome to join. And we will also likely to put on some other common learning events as part of this, so a continuation of our webinar series. Ward-based teams will have access to expert resources, both on our Futures platform and through our clinical reference group, which we'll come on to shortly. But most importantly, we hope to build an improvement network so people can share ideas, share challenges, seek resolution and innovate practice together. And we're going to do that through a number of fora, if you like. I've talked about the NHS Futures platform. I've spoken about the drop-in sessions, but we'll also be looking to set up WhatsApp groups, Twitter communities. There is this cross-fertilization between the 4 themes. So just to highlight, people are not restricted to one or another. You can join more than one. We've got the sharing and learning events, which we hope everyone will join and enjoy, and we'll be promoting the work that you're all doing through a fortnightly newsletter. Just so our academy is currently just being finished and will be launched, I think, next week, and it looks something like this. So you can see the Futures platform with a drop-down menu of folders on the left-hand side. It will be entitled ECIST Academy, and actually it will be full of bite-sized information, so little motivational videos, best practice webinars, best practice case reports, and evidence-based resources. The idea is not to overload you with things, but the academy has been curated by our clinical and QI experts of stuff that they find really useful, which we hope you will too. And the proposed timeline for this support offer and the collaborative approach is 4 months. And we've split it into 4 monthly blocks, starting today with our launch event. And the next month, you'll be supported in preparation for change and creating a movement for change on your wards. The second month will focus on quality improvement tools and techniques. The third month will have focused learning, and then we'll wrap up the collaborative approach with sharing, presenting and collaborating. Gosh, struggling with my words today, apologies. One of the key things about our collaborative approach will be the model for improvement. Most of you will be familiar with this from the Institute of Health Improvement in the States. But we will be looking to support you doing multiple PDSA cycles on the wards. And so over the next month, we'll be working with you to define your aims, define how you're going to measure whether your interventions have been successful or not, and to work with you around model for improvement principles. I'm not going to spend more time on this now, but there are lots of resources and we'll be running sessions to support you with this. I thought, however, I would just give an example of something that might be useful for ward and board rounds. As many of you are familiar, we ran a modern ward rounds collaborative last year based on best practice guidance from the Royal College of Physicians and the Royal College of Nursing and the Patient and Carer Network. One of the key learnings from that collaborative was the importance of involving patients, and from my perspective, how motivating that was for ward-based teams. And so one of the things that we looked at, which is best practice elsewhere, is the 4 patient questions. And so you can read them here. So the 4 patient questions, the idea of these are that every patient in every bed on every ward on every day can answer these 4 questions. So the first one is what's wrong with me? What's my diagnosis? Second question is what's going to happen to me today? Am I going to go for tests? Do I need to do anything? Third question is what needs to happen for me to go home? So, preparing, and this may fall into things like criteria-led discharge, but informing the patient and working with the patient so they know what's going to happen for them to go home. And the last one is essentially the estimated discharge date, or when am I going to go home? Now, I've looked at this on my own wards, and actually I was quite shocked even when I was on leading the wards for the month, when I think maybe a bit arrogant, but I like to think I'm a relatively good communicator. I'm relatively patient focused. But what we found was actually most patients couldn't answer all 4 questions most days. And so what I'd ask you to do, just as a simple test of change, if this is something that appeals to you, you can just ask one patient either this afternoon or tomorrow morning. Just take the first patient in bay 1 and ask them those 4 questions and record with a simple yes, no, whether they can answer them or not. And then tomorrow you can ask 2 patients, or you might want to ask 1 patient in each of your 4 bays on the ward, for example. And you build your model for improvement and your improvement journey in that way. So it's just a quick and simple suggestion, an idea for you to use. We fully appreciate the challenges everyone faces at the moment, and what we're trying to do is support little change and allow that to grow. So the next steps of the launch event today are we're going to hear from each theme, and then we're going to break into rooms where we can meet and share ideas. If you haven't done so already, please join the Futures platform, and when we launch them next week, have a look through the Academy pages with your team. I'd like you to, from today's meeting, go back to your team and think about any improvement ideas and see if you can start generating your aims. And we will link you with your ECIST improvement manager at the start of phase 1 of the collaborative approach to see if we can work with you and support you on your improvement journey. I can see there's lots of stuff in the chat which I haven't had chance to read through, so I don't know. I'll just quickly ask Erica, are there any questions, Erica, in the chat box that need pressing answers?
Not anything that I don't think we've answered, Andy, although there is a question from a colleague specifically about the meaning of the word only in the hospital only discharge work stream, but I've put a little bit of an explanation, although if colleagues prefer to have a further discussion, perhaps we can pick that up now.
Yeah, so thank you. So the background of this is that the National Discharge Task Force was split into 4 work streams. Work stream 1 was hospital only discharge. The other work streams, forgive me if I've got this wrong, but one was about community response, one was health and social care, and the other one was discharge processes, I believe. You can tell I'm only involved in one of them. And what we recognise now as that's developed is actually, unsurprisingly, good effective discharge needs all of those 4 work streams to work together. And as part of this collaborative approach, we will be focusing on hospital only processes, but also working with things in the community and hopefully health and social care ideas as well. So forgive us for the language and things and for not explaining that. So I think I'm going to hand over now to my colleagues Amit and Vince, who are going to present on the frailty theme. I'm going to stop sharing my screen and I'll come back on after Amit and Vince to field any questions. So Amit and Vince, many thanks.
Thanks, Andrew.
Thank you, Andy.
and hello. So I am Amit Arora, and I'm a geriatrician and a ECIST clinical director. I think the first slide is around why. So let's forget the frailty for a minute, and we are talking about why for the whole of this program. So it is always good to start with why. Why do we do what we do? And my why is to make a difference. And I feel good when I do good work, when I make a difference. And that's why I became a doctor, working more widely now. But beyond serving to tell you what kind of goals and tasks one should be pursuing in the first place, knowing why we are doing our work, it also serves two fundamentally important efficiency related purposes. One, it motivates us, and two, it orients us, it focuses us. So it's always good to start with why, and you'll have to find your own why. But for the purpose of today, coming to the second bit of it is frailty. So guess what is the one thing that is happening to us all right now, right here? We are all getting older together. We are all on that demographic escalator, whereas aging in itself does not equate to frailty. Frailty is actually more prevalent as we grow older, and frailty is also important because we have the data. So what does the data tell us? The data tells us that small number of frail patients can actually have a disproportionately larger, bigger impact on patient flow, outcomes, and their experiences. We also know that frail older people are more prone to deconditioning as well as other traditionally recognized harms of hospital stay, like infections, whether it is C. diff, whether it is MRSA, also DVTs, PEs, and all the other side effects of staying in the hospital, including institutionalizations into a care home. And many of you will identify that from your own experiences. So what happens if we get frailty right? So getting frailty right means better outcomes, better experiences for patients, and it also releases that elective care capacity and improves the emergency flow, and it also gives better return on investments. And what I mean, although it's not strictly part of this collaborative as such, but as Andy said, there are other aspects, other themes within the discharge support programs. So working together between hospitals, community services, care homes, ambulance services, primary care, all these things bring the workforce together and improves everyone's knowledge while we save patients time. And frailty, therefore, is everyone's business, and to get it right is very satisfying. And I can tell you that from my own personal experiences over the last 25 years practicing as a geriatrician. So we all in our own services have some bits around frailty, and this is about building on what we already have and add more to it by working together. And by working together, I don't mean just in the hospital. I mean blurring the traditional boundaries of primary care, secondary care, mental health, ambulance services, social care, housing, voluntary sector, and so on. And I see it in daily clinical work that if a system can work in a seamless way, the patient's journey and experience is much better and the clinical outcomes improve. So I would say that the opportunity is huge and the time is now, and older people deserve no less. So what are we going to do next? If I can have a few objectives here. So some of these things that we hope to achieve from these sessions on frailty. One is we hope to showcase good practice, including frailty scoring, frailty front door support, optimizing those timely discharges using home first principles, and other developments that you have, and the ones which are also around in various parts of the country. So we can tell you about those, we can signpost you to those, we can create those links, and we can help each other in developing our services. We also hope to use the huge amount of data that NHS has on all the hospitals and use that data to implement sustainable changes using a QI approach, whether it is PDSA cycles or some other approaches. and we will help you with those bespoke solutions, co-designed with you, for you. And last but not the least is to raise awareness of that system-wide frailty working to support patients' autonomy and independence. So I think those are the key objectives from my end. But let me also now introduce my colleague Vince to explain a little bit more detail on what is on offer next. Thank you.
Thanks, Hamid. My name's Vincent Baxter, and I'm an improvement manager with the Emergency Care Improvement Support Team, and my clinical background's in nursing. So as Andrew said in the introduction, there are a number of resources that are going to be available throughout the collaborative. Each work stream will be running a series of webinars, and the dates for the webinars for the frailty work stream are on screen now. These webinars provide access to subject matter experts, and we know from other collaboratives that we've run from ECIST that they've been really appreciated by the participants in the collaborative. So the webinars give that sort of access to those subject matter experts. Andrew also mentioned the ECIST Academy, so there'll be lots of resources specifically to frailty, but there'll be a wider set of resources as well available through the NHS Futures platform. We also want to kind of co-develop the learning sessions with you as collaborative participants and tailor them to the support that you need. So we're going to be running some sessions later this afternoon where we're going to start that process. But throughout the collaborative, we really want to kind of seek what you would like, what would be helpful to you. And finally, as Andrew also mentioned, you will have access to both ECIST improvement managers and also our clinical associates who are practicing clinicians but give time to ECIST, and Amit is one of our clinical associates who obviously specialises in frailty, but we have a number of other clinical associates as well that have that background. So that's just the learning opportunities that are available, and we hope to sort of kind of develop those as we go through the collaborative and make those available to you via the NHS Futures platform. What I would do is just direct you to the first date for the frailty specific work stream and the webinar, which will be on the 20th of June, and just to sort of keep your eye out for some more information around that. So that's it from myself and Amit. So thank you very much for listening, and I think we're going to pass over now to the workforce work stream.
Thank you, Vince. It's always really difficult to follow Dr. Aurora and Vince, so I've got the short straw, I'm afraid. So my name is Dan Smith. I'm one of the respiratory trainees here in Nottingham. I've been a clinical associate with ECIST for a couple of years, and I'm one of the leads for the workforce workstream. So as Dr. Rochford said earlier, there's 4 work streams, and I hope later on this afternoon you can join me and Richard Brownhill in a discussion to help shape our workforce workstream. God, that's a bit of a mouthful going forward. So, as Andrew said earlier, it was from the plans that your organisation has put in place that these 4 different work streams were identified. But why is workforce so important? Well, it's a bit of a trope, but it's really true. The greatest strength is our people. And I think that the backbone of all improvement projects is the workforce. I was asked not too long ago to go help a local organisation here in the Midlands who are really struggling with their discharge processes after spending millions and millions of pounds on a new e-discharge software and EPMA, all singing, all dancing prescribing software, and still struggled with their discharge process and couldn't understand why. And after a process mapping exercise, we realised that although they'd spent millions on a new computer system, they really hadn't engaged with their workforce, and the workforce processes really hadn't changed to match the new software. Also, in improvement journeys, workforce are often deciding to be too big a challenge or too long term, but we're keen today to show you a couple of examples of how small changes to workforce, including rotas and giving our staff time, could actually lead to significant improvements in patient flow and ward round processes. And we're also keen, as the last team talked about, to use some of the data that we all have around flow and workforce to show how improved methodology can be used and how that continuous data collection can help improve our workforce. So as we move on to the next slide, just to show you the objectives for this work stream, we want to help you guys measure, if I understand the pressures on the workforce. So what does that mean? Well, that means that we want to share a lot of the fantastic demand and capacity tools that we in ECIST and NHS England Improvement have. We can help go through those tools with you, and that means that we can model the pressures that your workforce have, how many patients you have coming into your organisations and how many staff you need to help deal with them. But also not just think about staff as a binary doctor, nurse, physio, but looking at their competencies across the organisation and who is the best placed person to see each individual patient from an acuity point of view, from a presentation point of view. And we also, within ECIST and within our collaboration and hopefully within the organisations we have on the call today, those 15 organisations, we'd like to share best practice around innovative workforce solutions. So that includes rota technologies, that includes international graduates and refugee nurses and doctors, and also novel recruitment strategies that other organisations have found successful to both recruit and retain members of staff. And we also want to think about more kind of qualitative data as well. So how can we support your members of staff? We're talking about well-being and burnout, but also education packages so they can become the best they can be within the organisation, and hopefully you can retain your staff as well. So that's our 3 objectives, and throughout our workforce, our different webinars will cover those objectives. And again, we have lots of resources on the NHS Future site for you to go through those ones with us as well. And each of those might seem quite big, but we're here to kind of help coach you and show you through those. So a quick example of why I think workforce is the backbone of all improvement. This was a project that was presented by the Leicester University Hospitals team from their clinical decisions unit at Glenfield Hospital, which is a mixed cardiorespiratory unit. And this was part of the Modern Ward Round Collaborative that Dr. Rochford talked about that we ran last year. So this is the poster. I can't expect you to read all those little small writings. So we'll move on to the next slide and I'll go through it in a bit more detail with you. So it's a very busy unit, 50 beds. Cardio and respiratory patients coming in both from A&E and directly from GPs, and self-presentations as well. And as a team, they got together to think, what could we do to improve patient flow and patient care in our organisation? And they wanted to prioritise in the morning which patients saw the senior doctors and specialty nurses first in order to improve patient care, improve safety and discharge quicker. So as a team, they implemented a huddle. They used that huddle also as an operational briefing to describe what the flow of the organisation was like, how many beds they needed, how many patients were coming in, and they prioritised patients down to acuity, MDT, who we had MDT input, who could go home today, and what expected admissions that they had coming in, and they saw those patients in that order. And they did multiple PDSA cycles, from memory, I think 5 or 6 cycles, and they took feedback from both patients and the team about how to improve things going forward. And the outcomes were the staff were delighted by the changes. They felt the organisation and the department worked so much better. The night team, this is mainly doctors, were leaving over an hour late after their shift because of the speed of handover in the morning. The day team felt they had a better grasp of the organisation. And although we can't claim any causation, but there was a correlation here, 33% of reduction in cardiac arrest over the 6 months when they did this project, and that's continuing. So just move on to the next slide. Why, therefore, do I think this is a workforce improvement? Because it seems to be a ward round or huddle improvement, but they had to work with the MDT to identify what were the main problems they identified. They had to also make time for those MDT members. So this included looking at their job planning and their rotas to get them at the huddle and to be able to take those tasks on after for the next couple of hours. That had to be done in a sustainable way. So the country's been in a project where people have shopped onto the shop floor just for a few weeks. And it was the feedback from that workforce that enabled them to do further and further improvement cycle. So just what are we going to offer you as part of this work stream? Well, again, we're going to have at least 4 webinars. We're going to have improvement experts, but also people who have had expertise in leading improvements in workforce across different areas of the country. We'll be able to coach you and show you different best practice examples. We're going to take your best practice examples and link you together and connect you. Some of your organisations may have got a really fantastic ACP programme. Other places may not do, for example, and we can link you in terms of sharing business cases and best practice. And that coaching offer for all the work streams will be available going forward. So that's it for me. Richard Brownhill couldn't quite make it as yet. He's on a train at the moment, so he'll join us later in the breakout rooms. So I'll hand over to Callum and Colette, if that's okay. Thank you.
Hi there, everyone. Good afternoon. So my name is Callum McGregor, and I'm another one of the improvement managers with the Emergency Care Improvement Support Team. I'm a physiotherapist by background, and I've been with ECIST for the last 3 years. I'm mainly working down in the south of the country just now. So I'm going to talk to you about the ward and board rounds work stream. So there's myself, Dr. Andrew Rochford and Colette facilitating this afternoon in terms of the breakout rooms in this presentation. So why ward and board rounds? Well, I think what's been very clear since we've been on site, especially since January, is that we'll walk onto one specific ward and we'll see some very good practice, but then we might go to a different ward and then it's not as consistent, it's not as structured or organised, there's not the same people that are there. So I think it's really about getting back to basics. It's about making sure that we're following procedure across all wards, making sure that people learn from each other, so that if something's happening very well on one ward, then we could try to share the learning from that, so that we've got some peer challenge and some learning there. What we want to do, obviously, with hospital flow is if we're going to have good ward and board round processes, then hopefully we'll facilitate earlier discharge within the day. And certainly we know from all the data around criteria to reside and the time of discharge, lots of people are still in hospital that don't need to be. I think the main thing we do see, and especially when I put the link in with what matters to you, is about what the patients know about their own journey through the hospital. So can they articulate to you, the staff, or to their relatives about what's happening to them? I think also what we want to do through the work stream for ward and board rounds is try to provide you with both short and long-term ideas on how to change. And some of those things can be very simple about maybe on a ward round, you might want to introduce yourself so that everyone knows who everyone is. Because certainly when I've been on site, not everyone wears ID badges and it's quite difficult to tell which staff members which. There's an opportunity, hopefully, to share best practice. So we can use the Modern Ward Round Collaborative. There's also lots of work that ECIST have done in trying to implement board round good practice. And then we will, as always with ECIST, we want to be clinically led and data driven. So we want to use data to monitor our progress. So we'll go on to the next slide, please. So as with all the other work streams, we have 3 objectives. So the first one is we want to provide this best practice guidance. So we've got some self-assessment templates that we can share, and we'll probably go into more detail on that in some of the learning webinars that we do. We also want to demonstrate the impact of patient and staff involvement in the ward-based improvements. So similarly, like Andrew said in the introduction, if you were to ask one person on your ward as to what the 4 questions were, and then you re-audited that the next day, or you did several patients over a week, you'd want to see an improvement in some of those answers. I think also if we were to look at the board round and the time of discharge within a particular ward, I think it's up to the ward themselves to kind of own their own data. So you want to maybe think if the normal time of discharge might be later in the afternoon, we might want to bring that forward. So I'm slightly melting in here because I can't change the temperature in the room. And then of course we want to use that data to drive. So you need to know what your baseline metrics are just now, what metrics you want to look at, and then figure out how you're going to improve the flow on the wards. So the next slide, please. So this is the document that came out last year with the RCP and the RCN. And most people will obviously know that in order to do a good ward round, it needs to be well led. It has to have structure around it so that people know when it's happening and who's going to be there. It has to have effective teams so that there's some people maybe writing down actions as what's going to happen, that the patient knows exactly what's happening, and that they are involved within the decision making. And then you want to be able to use the ward round, because certainly from my time as a physio, when we used to go on, especially when I was working in HASU at King's, we would go around as an MDT into the hyperacute stroke unit, and it was a time for education and learning. So the consultant might give you a new study that's just come out in terms of stroke outcomes. I might be, as the physio, be able to provide some input about getting people up and moving after early stroke. So it's really about, it's not just about sharing information with the patient and junior doctors or nurses listening to the consultant, but it is about that kind of learning improvement and collaborative approach. Go on to the next slide, please. And this is just, again, there's nothing new here, particularly in terms of what should be around in a good board round. But similarly, there are lots of inconsistencies when we go. Some board rounds don't happen quite early enough in the day to promote flow. There might not be that senior clinician, so there should be the consultant or a senior registrar, certainly at the board round, and leading on that. And also it's a skill that other people, so maybe AHPs or the nurses, can physically lead the board round, but we'll have the consultant there to make the decisions. You want good MDT representation, because when someone asks a question about what's happening with discharge, whether that's to do with diagnostics, whether it's to do with what's happening at home, any kind of onward referral to a different team, people should be there with the answer. And if you yourself aren't involved with that patient, at least get some handover from your colleagues. I think there's lots of models around, so the safer patient flow bundle, the shop, in terms of who you go to see first, etc., on your ward rounds, not just starting at bed 1 and going to bed 28. And then just being proactive, because I think when someone comes onto your ward, we should certainly know within the first 24 hours is what we're expecting to happen to that patient. And then there's something about escalation. So if you as a ward can't fix some of the issues, or there's a delay to discharge, there should be a clear escalation plan that everyone should follow. So that might be going to your matron, it might be going to your director of ops, it depends on what the issue is. And that shouldn't just be email communication as well. It should be telephone calls or face-to-face conversations, so that you know what the answers are, and then coming back to an afternoon huddle to be able to say what kind of progress has been made on those actions. Next slide, please. And again, I won't go into too much detail here because you've seen it twice before already, but we will be having some learning opportunities. We'll be leading on some webinars, and we're always here in terms of at the end of the phone or on email for us if you have any specific questions you want to ask in terms of this work stream. And certainly if we don't know the answers, we've got lots of other national colleagues who we can signpost to. So I think that's it, and I'm going to hand over for the final work stream for Dr. Ben Owens and Andy.
Thanks, Callum. So yeah, thank you. The operational processes work stream, which is a bit of a combination, as Andrew said at the start. Next slide, please. My name is Ben Owens. I am an ECIST clinical associate. I'm an ED consultant from Sherwood Forest. Why we're doing it? It's about operational processes. It's how you make the hospital flow through the system. What are the principles and outputs of it, and they're allowing each individual place. Actually, you need to design your own process, but it's the outcome and the principles that is key to sharing this. There's opportunity to share your things across your organisation, opportunity to share them between organisations, and because actually there's lots of good stuff everywhere, and stealing with pride is a great thing to do. Into the NHS, and finally, what are the thorny issues? What are the tricky things? What's hard to handle that get these things stuck? And actually, what we often find is lots of organisations have the same issues. And again, it's showing those solutions, but also sometimes showing the pain a little bit as well. Actually, what are the tricky things? Examples being internal professional standards. Most hospitals admit thousands and thousands of patients a day across a year. Sorry. And if you do that with thousands of staff, you've got to have some rules in place. If you haven't got that, you get increased risk, you get problems. And actually, internal professional standards need to reflect the values of your organisation and what is important to patients, most of all. Focus is an example of a principle for looking at flow. Criteria reason to reside, or criteria to admit. What really doesn't matter what system you use to look at your inpatients. It matters, could I make a different decision? Could we do something different with our patient today, decision wise, or actually is there a gap in our service that would allow us to discharge a patient if we had something else available to us? The two is to look at how you're, and the final thing is, these days we're very wedded to consultant-led discharge, and actually consultants are a sort of a rare and precious resource out of hours at times, and actually a lot of the time nursing staff and junior doctors can discharge people from hospital quite comfortably, but that's about the clarity of our plans and what we do and how we make our notes, how we clarify those plans to enable our staff to do it. And the 4 questions is a great example. So as Andrew said, the 4 questions, every patient should know them. I would also suggest every staff member on every ward looking after your patient, you should know them for your patients. Because if the patient knows them and you know them, then, and if you go and ask your patients and ask the staff as well, I suspect you'll find that the staff looking after those patients couldn't always tell them. If they can't, then it's suggested that the planning or the communication of the planning isn't there with our patients. Operational process stuff is really fundamentally about managing the risk in the organisation in terms of flow. So flow is managing risk. Delays and crowding lead to harm, and prolonged length of stay in hospital for the elderly particularly is at risk of deconditioning and hospital-acquired harms as well. The real challenge we have at the moment in the system is that if we don't get this right and we get things caught up, then actually when one person stays in 1 day longer than they need to, or one person is admitted when they didn't need to be, then potentially 4 people are at best have a poor experience. So they're stuck in hospital. There's a person stuck in a ward who doesn't want to be there. There's a person in ED trying to get into that bed for a prolonged period of time. There's a person in the ambulance outside the hospital trying to get into that ED, and there's a person in the community who's waiting for that ambulance. The longer those delays are, the further to the end of that list you go, the greater the risk of harm. At best, it's a poor experience. At worst, serious harm and even death can occur with that. So actually, this is a really important thing. So when we're looking at flow in hospitals, we're actually looking at individualised patient care, and that's sometimes lost. And that's part of the messaging we'd like to get through. Next slide, please. So optimising pathways and balancing risk, as we said, what's the best patient pathway, and how do we balance risk? And risk is often seen as a binary thing, and it's not. It's a spectrum, and actually in that spectrum, so what are your responses when you're a level 4 escalation? They have to make a different outcome. You may change that risk as a result of it. It has to be sustainable. There's no point in doing something on a perfect week and then finding out we need 5 more doctors on that ward and it doesn't work. So it has to be a sustainable approach. And actually, what are good standards? We've talked a bit about that. Right? What are things you can use and share that are out there, or will adapt to your own organisation? Next slide, please. As before, learning opportunities as webinars available, resources and futures, and we want to develop the sessions with you so we can support you. What matters to you? What is things you want to work on? And actually offering coaching and things as people have already said. Next slide, please. Thank you. A few questions to think about with operational processes and that kind of thing. We like to think about are things like, if my relative was admitted to my hospital through the ED today, I don't know, at the back of the queue, would I put them through the system and say nothing? Would I phone a friend and say my aunt, uncle, wife, husband is coming through the system, can you make sure X, Y, and Z happens? If that's the case, then actually there's opportunity for improvement in the system. And I suspect many of us would say that. So actually, a really good test. What would I expect from my relative, or in terms of discharge or admitting? What would I expect? It's a really good test of your process. If my relative went through this system, this internal professional standards, would I accept that? And if we wouldn't, then no one should accept that. So these are little tests we can do to do that. But we're really looking forward to working with you all.
Ben, thank you very much. Or just for the record, not Dr. Benjamin Owens. So Ben, as we're known. Thank you, everyone. I hope that's given everyone on the call a little bit of a flavour for what the themes involve. And what we're going to do now is ask you to select through the chat. There are 4 links to break into little rooms for, I think, 30, it won't be 30, yeah, maybe 30 minutes for each of the 4 rooms. Don't worry if you, to be honest, if you're not entirely sure, just join one of the rooms that you're interested in, explore it, and we'll be working with you after this to sort of finalize things. So just join one of the other breakout rooms. You have to go through the chat, I'm afraid. So join the breakout rooms and we'll see you back in this main room in about 30 minutes. So thanks very much and see you all shortly.
Hello to colleagues who have come back into the room. My name is Erica McGuinness and I'm an improvement manager working for ECIST and part of the steering group for the Hospital Only Discharge Collaborative. So hopefully you'll have had a really good opportunity within your groups to have some constructive discussion, I guess, about the elements that you might be keen to explore. I'm conscious, of course, that many of you will have only joined the one room, and given that there were 4 topics for discussion, what we wanted to do in this last section is ask each team to kind of feed back a brief summary highlighting the kind of key points that they had an opportunity to discuss, which will give you an opportunity, I guess, to reflect on some of that discussion as well. So we'll do that first and then we'll wrap up and I guess go back on the most important things we'd like you to consider over the course of the next week or so. So if we had to start with frailty, Vince or Amit, is any one of you able to share some thoughts? Oh, they're still coming back.
Yeah. Amit's just joining, so I'll start. So I think one of the we had some really useful discussion about risk, and I think it's Richard Jennifer's point around risk blindness, and that was definitely a theme that really stood out, that very often we are blind to the risks that we are causing frail older patients by keeping them in hospital, and I think that kind of linked nicely into the point that Ben Owens was making around about it's not just a poor experience for one patient. If we're keeping someone in hospital longer than they need to be, it's a poor experience for them, but it's also a poor experience for other people that want to get into that bed. We also knew when we were designing the collaborative that there would be some cross-cutting themes, and workforce came up when we talked about challenges. So there's definitely some challenges around sort of developing an effective frailty workforce. And the other thing that stood out was around the issue around frailty operates across the system, and there was some quite interesting discussion around what we should be doing to prevent people turning up at the hospital front door in the first place, and what that requires from a system to allow that to happen, and then moving to the back door of the hospital, what needs to be there in terms of the system to be able to allow us to move patients out of the hospital when they're ready to go. So I think they were the three themes that were really stood out: risk, the system, and workforce. I don't know whether Amit's got anything he wants to add to that, or you, Erica, because you were in the session.
I think you've covered it beautifully, and I'm also conscious of time, if that's okay, so we'll just let the other three groups share their feedback. Dan, any reflections from a workforce perspective?
Well, many, but just to keep it brief, I think firstly just showed how everyone values the kind of the colleagues that everyone works with, and the kindness and the energy that everyone kind of has to support each other and their patients. That was very clear initially. And then the two things that I think were the biggest asks of ECIST and the collaborative as a whole was, one was being the voice of staff and energizing them and helping them maybe have difficult conversations in their own organizations and trying to find them time to develop innovative solutions. And then the second one was sharing best practice, so connecting guys within the collaborative, but also we had some really good examples from different organizations across the country as case studies that we could share with each other as well. So I think they were my main reflections.
Much appreciated. So moving on to ward and board rounds, Colette.
Yes, good afternoon. We had a very interesting and detailed conversation. Chester, I have to say, were very hard on themselves, but spoke a lot and lots of great things there. Regarding the feedback, I suppose we need to be realistic about the workforce. The workforce are, we all know, are pulled in every direction. The capacity and availability. So even it can't be used as a task and finish group. This is the start, this is the end. It needs to be repeated daily. The consistency isn't there, and I think everyone recognised that. How do we keep it simple, and how do we ensure that this isn't another job on top of the jobs we're already doing? Then staff are quite keen to understand how that could happen. It was good to talk about how we engage and ensure that this isn't, as I said, that it's part of an addition. And basically, I think lots of opportunity on safe practice, but I think the strong message was the consistency and how we ensured staff feel supported and the quality of the information for handover.
Thank you very much.
Anything, please add. My group.
Okay, last but by no means least, operational supporting processes. Ben, are you feeding back?
Yeah, can do. Yeah. So I think a couple of things people are proud of. So we asked that what you're proud of with operational processes, the right team, direct specialties, taking people directly first. Important thing about leadership, aligning medical and nursing staff to the coup, and how in doing that you get operational stuff better. MDT plans for discharge for patients, sort of things. Some of the things that are the barriers to improvement, sort of culture and behaviour came up. How do we change culture and behaviours? Speed of change. How do we make change happen quickly? And then with that, time for sort of teams to get time. I mean, rather than firefighting constantly, time to effect change, and what we could do with that. And I talk about the difficulties of sustained escalation. Lots of hospitals are currently in that sustained escalation period. So actually, how do you get time out from that? Because it's exhausting and it consumes a lot of energy, and certainly it can be an impediment to improvement. With some of the things we talked about.
Thank you very much. I think there's certainly been some really useful and productive discussion, but there's also some thinking, I guess, that we have to do as a group, as a steering group, to make sure that we can kind of progress the programme in a way that is meaningful and adds value. And I think that creating space for teams is, for me, I guess, on a personal level, something that we would definitely want to reflect on. We've got 1 minute to go, so Crystal has just posted an evaluation form. We'd be really grateful if you could take some time to just share your thoughts about the event. Your feedback is always important to help us improve these events as we go forward. We've obviously shared quite a lot of information with you today, so what we'd like to ask you to do is to take some time and reflect on the discussions today, to share some of that with your teams, and to perhaps start to think about the areas where you might like to do some work across the 4 key themes. We're more than happy for you to be flexible, so where there's a mix and match approach that can be taken, it needs to work for you, so we will be as flexible in our response to make that work. The workshops, as we said, start on the week of the 13th of June. We've purposefully left a gap in August, reflecting on the fact that it's obviously kind of peak holiday season. So some dates and key joining instructions will be sent out to you and your teams over the course of the next week. The improvement managers will also make contact. So there's nothing further for me to say except to thank you very much for making the time today. We hope you found the conversation useful. And finally, a thanks from me to all my colleagues in ECIST as well, who have given up their time to help us coordinate the event. Thanks very much, everybody. We'll see you soon.
Thank you.
Thanks, Erica.